Hello, I'm David with Vascular Anesthesia.
And I'm Crystal with Vascular Anesthesia.
Today we're going to talk about topics that are interesting in the anesthesia world that most patients do not know about, and we're going to give you a full disclosure of what goes on in the anesthesia world.
I fell asleep last night, drops on my pillow. I have no peace of mind, and this might never change, never change.
So today, I think we want to start off with Michael K. Williams.
Oh, wow.
He's been in the news lately. He died of an overdose recently of fentanyl and heroin.
Yes. These drugs are very dangerous. I mean, now they are taking these drugs, either it's cocaine or heroin, and usually they're basing it out.
Right.
They were kind of trying to stretch these drugs, and they're stretching it with, prior there was baking soda or something that would make it a base to make it last longer and make more sales. But when you take something like as cheap that's made in China, something that's fentanyl, or drugs like that to kind of cut these drugs with, yes, the patient would get higher, I don't want to call him patient. The person will get higher that's abusing these drugs. They'll get higher, but your clientele would go down because people are dying from this.
People are dying because you have to remember one of the things that happens with the fentanyl is it slows down your respirations.
Yes.
And slowing down can progress all the way to stop.
Yes.
So you have fentanyl, which is going to be definitely a downer. It's going to slow your respirations, possibly, depending on how much you take, cause you to stop breathing. And then heroin, which is known, to overdose people where they stop breathing. Exact same thing. You add the two together and you get what we call like a synergistic effect, which means one makes the other one, they join forces and they become like this super drug.
Yeah, it's
people are dying.
It's like Hypnotic and Hennessy, huh? Incredible Hulk. You mix two and you got Superman.
You got Superman.
So it's these drugs are not meant to be mixed. Fentanyl alone is a powerful drug. It's 100 times more powerful than morphine. So once again, these drugs in the wrong hands are very dangerous.
Right. I was just thinking, we won't even give fentanyl when we're trying to wake our patients up at the end of a surgery. That's a major no-no because you can be sitting there for a long time waiting on somebody to wake up after you give them some fentanyl.
Exactly.
For them to even breathe sometimes.
Oh, my goodness. These drugs are very powerful. I mean, and I
Very
feel bad
powerful.
for Michael K. I mean, I love them on these shows. What, it's The Wire?
The Wire.
Oh, I love him as Omar. He come in and, Omar cleaned things
Omar,
up.
yes,
He was a killer, But he was an honest man to those who he loved. He gave his heart. And it was, I want to pray for him and his family,
Absolutely.
Our prayers go out to him and his family.
Absolutely.
It's a loss to the community, from what I was reading. He was a pretty good man.
Right. Drug addiction is a beast, and you just don't even want to get on that roller coaster.
Well, it's something that it doesn't discriminate against gender, race. It don't matter. It doesn't care who you are.
It doesn't care how much money you have.
Exactly.
It doesn't care how much money you don't have.
Yes.
I mean, it is taking
No discrimination at all, financially, nowhere. So if you take it, you bear the risk of becoming deceased. So, and mixing it with these already highly addictive drugs, and fentanyl is very highly addictive, you're going to have some pretty bad outcomes.
Yeah.
Rest in peace, Michael K,
Absolutely.
Rest in peace,
Prayers for his family and their strength.
So, just as we were talking about previous weeks on, administration of fentanyl, and then you have these companies over in China that's making this synthetic fentanyl. These drugs they may package 100 milligrams or 50 milligrams on it, but these drugs could be 1,000 milligrams.
I was just about to say, you actually don't know how strong the drug is. And I mean, whether they're selling them as patches or you're smoking it or, you're injecting it, you have no idea what you're injecting. And a lot of times the synthetic is worse than, what we make in the labs.
Yeah, and it's highly addictive. I've known nurses to get on these drugs that work in the ICU, and it's hard to get off of these drugs. They are very, very addictive. It is a phase where they try to do these detox phases, and it's terrible. That's how Prince died. This is how a lot of entertainers, they die from these drug overdoses. But fentanyl is a drug that you do not want to touch.
No, you don't.
Not only are RNs taking it, anesthesia providers, that's the drug of choice that they turn to.
So, of course, I got a story for you.
Oh, yeah, let me hear that story.
Okay, so I am not going to name any names.
No.
I am not going to say any facility names, but at a very prominent facility I know of, there was one of the medical doctor anesthesiologists. He was basically a dealer for the nurses on the floors and up in the units working, and he was stealing the fentanyl, and he was taking it up, and he was selling it to the nurses. I mean, he was a dealer, and literally they had to do sort of a sting operation, if you will, and they had one of the ORs, they had the cameras on it, they had, set a bottle of unopened fentanyl, up on the anesthesia cart, and it was as if somebody, whoever the CRNA or the anesthesia doctor was that was setting up the room, it was as if they had, just kind of left it and forgot to secure it. And he came in, sure enough, took it, put it in his pocket, and when he did, they came out of the woodworks and sent him to rehab. But he still works right now.
That's crazy. You got a guy who's making $300,000-$400,000 a year or more if he's a partner. He taking it to the streets, and he taking it to the corners of the hospital.
He was cleaning up.
Yeah, I bet he was.
He was
highly
making a killing.
Yeah.
I mean, and they were buying it.
What do you think he is? Tommy off of Power or something? A Ghost off of Power?
He was Ghost.
Okay. Say less. Say less.
That's right.
Ghost. Okay, Ghost. You look. You can't be over there. You can't be slanging and banging at the same time. You can't be over there collecting the check from these hospitals and these companies, and then going over and doing your own pharmaceutical side hustle.
He was getting paid twice.
Man, don't be doing that. That ain't right, Ghost.
You work and you hustle all in one.
All in one place. Then your mama tell you don't eat where you sleep at. Knowing you go get caught. What is wrong with you, man?
He was doing it.
Oh my goodness.
We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. We are vascular.
We are vascular.
I fell asleep last night, watching drops on my pillow. So,
these drugs are highly addictive, and
They are.
We just informing the public, and we want to let y'all know that, I seen Pop for Raising Cane last night. It was a spinoff of Power.
Oh yeah.
50 Cent show, and he went to go cook. Basically, he went to go cook up the cocaine, and he called it some Williams, Carolyn Williams, I don't know, but it was fentanyl. So he didn't know what it was. He said, "Man, they just say cut it with this." So they cut it with that. They rocked it up, whatever. You know, I heard how to rock it. I'm not heard. I seen on TV how you rock it up, right?
On TV, right.
Yeah, on TV. So, you know, not in chemistry class where we learn in chemistry. I ain't learned that. Not at, you know.
Not the actual.
Shout out Southern University.
Not the
HBCU.
Structure.
But,
HBCU.
but yeah, so, Breaking Bad, yeah, nothing like that. But he cooked it up, he cut it, and they tested it out, right? They have these testers, and they go and they take it to the streets of these, this is the best way to say crackheads.
Right.
So the crackheads go test it, and they were dying. And no more customers, you know. So when you start killing off a certain population of people, people start caring because they were selling in the prominent neighborhoods. But when you selling in the prominent neighborhoods versus the neighborhoods that nobody cares about, like Baltimore, you know, streets of New Orleans, 35th Ward, you know, 7th Ward, you know, nobody cares, or 3rd Ward of Houston, nobody really cares about those areas. When people start dying in prominent arees, it's a problem.
Then it becomes a problem because everybody can see it then.
Yes, and it's front street. So don't, you know, these fentanyl, this is a real, it's a real problem. It's not a problem in the hospital, but it's a problem on the street with this synthetic fentanyl. So it's a real big problem, but it can be, you know, it's like any other drug, you know. Can it be less of it? No, somebody wants to spray this drug anywhere, they go put it anywhere. Like they're doing, they getting it from China.
They're getting it,
and they're getting it from anywhere. And then people are looking at the formula and they trying to make it themselves. So
exactly,
you know,
and it's a chemical, so it can be made. You just have to have the formula.
Yes.
And then apparently you do your marketing and your research out in the streets. And you just have to choose. This is a whole business class. You just have to choose. You just have to choose your market. You know, apparently they were choosing a market that they felt no one would miss. They tested it, and they found out that this is a little bit strong. So maybe let's not kill off, you know, our customers. So let's go back to the drawing board.
Let me find out you the king of boys.
I am not the king of the boys or the girls.
That's just what you heard, huh?
That's just what I heard.
Well, you know, that's what we heard. You know,
I was watching TV.
Yeah, you know, that's what we heard. So, you know, anesthesia in the street versus anesthesia in the hospital administered by professionals. Everybody think they're gonna die. They have surgery, right? It's 1 in 100,000 chance of you having an episode of fentanyl event or somebody dying from actual fentanyl. You know, we're not going to overdose you fentanyl in the back, you know. No. You're not going to just stop breathing from that. You know, we can give you Narcan, you can wake it up.
I was about to say, even if we do, we got Narcan for that and we know how to use it.
Yeah, but in the streets, police officers carry Narcan and, of course, paramedics. I think firefighters. So if they get to you in time, which majority of the time they won't, fentanyl, they acts pretty fast.
Right.
And the volume of distribution, by the time it gets to you, it's going to be in your system a while and it's going to take its effect. Whether the side effects are what Crystal were talking about earlier, the slower respirations, you know, you can have chest wall rigidity.
That's a major thing.
It drops your blood pressure. You can do a lot, you know, hemodynamically, but you don't have monitors on in the street.
You don't have monitors. You don't have all of the breathing tubes to protect your airway. You know, you don't have the drugs to reverse it. You don't have any of those things.
You just got whoever you shooting it up with.
That's it.
And let's not get it twisted. You ain't just crackheads taking this.
Absolutely
you
not.
You got CEOs, you got business people, you got
soccer moms.
Yeah, soccer mom.
Oh yeah, the soccer moms.
Yeah, they over there. They taking this fentanyl. It's highly addictive. So you know, everybody think, those crackheads over there is taking those drugs and doing this. No, cocaine is usually used, if you do your research, by a prominent group of people.
Absolutely, because it's expensive.
Yes, it's not like you know, Whitney Houston said
Crack
it best.
is whack.
Say
Crack
it again.
Is whack.
We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. vascular.
We are vascular.
I fell asleep last night. Wanted drops on my pillow.
Okay, so switching gears a little bit. Next, we're going to talk about consents. Anytime that you go in to have a procedure, you sign a lot of paperwork, and you sign a consent for the procedure that you're actually having, and then you also sign a consent for the anesthesia that you're going to receive during the procedure. So the question is, what exactly are you signing when you sign a consent, and what does this consent say?
Yeah, I mean, the first thing it's saying, am I signing my life away?
Or am I buying a car?
Two of the major things.
That's two of the major things. But first, what the consent is going to go over is going to tell you exactly what type of anesthesia you're getting. Are you getting general anesthesia? Is it local? Is it regional? Is it going to be a TIVA? It's going to explain exactly to you what type of anesthesia you're getting and what all that entails. If it entails, some type of device to protect your airway, or does it, just entail you just getting oxygen? It's going to give you kind of a small overview of the type of anesthesia you're getting. Then also, it's going to tell you the risk involved with all of those different types of anesthesia and just anesthesia in general. And it might go from everything from having a sore throat, which is very, very minor, all the way down to, death, which we said is 1 in 100,000. However, you need to know and understand that when you are signing this consent, you are signing saying that I do understand that one of the risks of getting anesthesia is death, even though it is a very small percentage. What the consent is trying to do is help you to make an informed decision about part of your health and your care. And you absolutely have the right on any day of the week for any procedure that you are receiving to refuse anesthesia.
Exactly. Consents also explain a little bit about the risk factor, like respiratory depression. It'll tell you that you can be in a coma. It can tell you that it's a lot of things on that consent.
It's a lot.
But
nerve damage.
Yeah, nerve damage. You can have eye damage from getting poked, your corneal abrasion, stroke, heart attack. Yeah, it's a lot of things that's on that consent. And, we will go over the consent with you. It's nothing that we're trying to hide, even though your procedure is it's not without having any type of risk.
Right.
It's
so
risk
I have
and
a question for you. If I am a patient and I'm laying here in this bed and you're telling me about this consent and getting me to sign it, if I don't understand, can I ask you questions?
Yes, you can. You can ask me questions. One. Two, which is major, that happens a lot. A lot of people do not speak the same language as you. So you have to have an interpreter to come explain, one, your surgical procedure consent, and secondly, your anesthesia consent. Because we want you to fully understand what you're signing up for. We're not trying to push this down your throat. But I would suggest that you have anesthesia, but we will have to let you know that it's risk involved with having anesthesia.
Right. And as a patient, you have a right to choose.
You have a right. So we want to just always just keep you guys informed with, things that could happen. Risk factors, type of anesthesias Crystal talked about. Even going as far as basically you have to put your signature on this thing, or you have to have someone that's have the power of attorney to correctly put their signature on there.
Right. Also, let me say this. You do not get to choose what type of anesthesia you get.
Yes.
So as an anesthesia provider, it is our job as experts in the field to know what type of anesthesia is appropriate for your procedure. And you can't say, I want conscious sedation, if we're doing a big belly case.
Right.
And we're going to, cut you from here to here and, open you up. You can't say, I want conscious sedation or I just want a MAC. You don't get to choose that part. But if you don't want anesthesia, probably what's going to happen is your case is going to get canceled.
Right.
But that is your choice. But no, you don't get to choose what type of anesthesia you have unless usually if you go up, we're okay, but we're not okay with you coming down.
Yeah.
If you need a general anesthetic, we're not going to allow you to have like just a MAC, but if, your case per se is like a foot case and, you want a general and you want to go all the way to sleep, we'll decide how asleep you need to be. And if a general is appropriate, then we'll put you all the way under.
Yeah,
but if
it'd be simple as an ankle block and probably some alfentanil or fentanyl and Versed and can probably get that patient through that procedure.
Right. And you don't have to go all the way to sleep and get the gas and, the tube and all of that, because sometimes, for a case like that, it's overkill.
So patient come in, right? This is a quick story. So patient come in, I was going to ask you a question, but they always come in, they like, look, I want 100 of fentanyl. Look, buddy, don't give me no more. I want 100 of fentanyl, give me 2 of Versed, and you make sure just a little bit of propofol. Of course. And it's, you looking at them like, okay. So what I do? What do David do? I give you that. And then you're sitting there looking at me. Where are you going to get started? I'm like, I gave you what you wanted.
I gave you what you asked for.
And then, then they like, dang. I'm like, look, I understand that you love control. And nobody can control your life but you. But we want you to trust us in the process. Basically, during the pre-op, we're going to have these discussions with you. We're trying to build trust, You are not a practitioner. I don't care if you are an anesthesiologist, Once you lay on that table, you're a patient. You can make a lot of suggestions, but ultimately, we're going to take care of you. As Crystal said, the type of anesthetic that you choose, it may be that you want. It may not be chosen for you to have. Right. You might not have regional or general. You might not have a MAC case. You might not have local. We're going to pick the best anesthetic that's catered for you. Everybody don't get the same anesthetic.
Right.
People are sicker.
Yes.
People can't take as much. People are allergic to drugs. So
your little 98-year-old mommy that was at home by herself, and she was cooking, and she tripped over the rug, and she fell and broke her hip.
Granny in that hip.
Granny, high blood pressure. Granny got diabetes. Granny is just barely hanging on, and she's frail. Granny is 79 pounds soaking wet. We are not putting Granny to sleep. Granny is go get a regional. She go get a spinal, and we're going to do this case, and we're going to keep Granny.
And then we have to watch the spinal because make sure she don't have aortic stenosis. So,
exactly.
It's ways that we make sure these patients are taken care of. But trust me that we will pick the best anesthetic that's catered for you. And
then we do discussions, kind of like what we just had.
Yeah.
I was like, we're going to do a spinal. David's like, well, you have to, think about aortic, the stenosis. I'm like, oh yeah, you're absolutely right. And we talk about these things. So, just know that, like, we're not picking these things because that's what we want to do. And, we're just going to, bulldoze you into doing what we want. We're picking these things because they're what's best.
And then, truthfully, no one has an ego problem in the back when you have anesthesiologists or CRNAs, because egos kill people. And, we're going to pick the best anesthetic. You have anesthesiologists that they want to do their things because they've done more cases sometimes. But when they trust you, as they trust the CRNA, they say, hey, yeah, okay, I can see how, it's not like just a, hey, you're going to do what I say. Sometimes it's a discussion, but you do have some anesthesiologists that don't care what you think.
But they should.
You know, and you have to do what they say, because ultimately it's their case, and we're practicing on our license. But you know, it's ways to try new things and cater to basically to their needs and their demands, because they're very smart at what they do, and they are the highest professionals at what they do. So, you know, they take everything into consideration, and we do too. So,
Can you work without an anesthesiologist?
yes, you can. Everybody thinks, a lot of surgeons think that, you know, you need an anesthesiologist present in the workplace in order for you to practice anesthesia. No, you need a licensed professional anesthesia provider to give drugs or provide anesthesia, whether it be a CRNA or a nurse anesthetist. Now, they can put you to sleep, take care of you. Nurse anesthetists have the same thing that anesthesiologists. Are we the same? No. Do we take care of patients the same? Yes. Do CRNAs or nurse anesthetists put probably 95% of the patients in America to sleep?
Absolutely.
Yes, that's correctly right. No, we don't need an anesthesiologist.
We're independent practitioners.
Independent practitioners.
By law.
By law. You can practice on your own, but you have to be very safe, you know, and you can have these medical boards or anesthesiologists say, oh, they're not safe. You know, and some anesthesiologists are not safe either. Some surgeons are not safe.
Absolutely.
So if you are basically a weak practitioner and, you know, mistakes happen, you know, and it's not only that a mistake happened, things happen to the best. So, you know, you have to pray and go in and do your case and you come out.
We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you're sleeping with excellence. Thank you. We are vascular.
We are vascular.
I fell asleep last night, wanted drops on my pillow.
So we back and we talking about anesthesia. So let's have a discussion that's basically it's not really a discussion, because I don't even know why it's even a discussion, but let's inform the public about this.
Okay.
So in some places, you have RNs, registered nurses,
Right.
giving fentanyl and Versed.
Right.
Fentanyl and Versed, according to basically AANA guidelines or medical guidelines, anesthesiologists, Association of Anesthesiologists, this is anesthetic. So the question is that some people try to bring in RNs versus CRNAs.
Okay.
So it's really not a discussion. A RN cannot administer an anesthetic. A RN cannot administer anesthesia.
Right.
Only a CRNA who is licensed to do that can administer an anesthetic. So when a RN administers an anesthetic, it is by the direction of that surgeon or physician that's
Exactly.
doing the procedure. So really, the surgeon, they're giving the meds and delegating it to the RN. So if there is a problem with the case, they get too much fentanyl, some doctors, they give some RNs a little leeway. You know, they say, oh, they've been doing it for so
Right.
many years, you know.
Right.
But they're still not licensed to do it.
Exactly.
So when they have problems, they can't intubate. They're not CRNAs.
They are not.
So CRNA can intubate a patient, put a breathing tube in, get them back breathing. They know how to mask a patient properly without
Exactly.
causing nerve damage and without killing them.
Exactly.
Without insufflating their stomach with air.
Exactly.
So when you have a CRNA, you have a complete, basically you have an OR ready to go. So
Yes, you do.
when you have an RN, you're limited to a basic office. When you bring a CRNA in to your practice, you basically have a operating room. So liability insurance, basically, we have our own liability insurance.
Right.
We are covered. There have policies at 200, 600, even 1 million, 3 million, or even higher. You can get as high as pretty much you want. But we have malpractice, and the physician, if it's anesthesia related, it's on us if it's a problem. But when the physician is directing the RN to give medication, that falls directly on the malpractice of the physician, and they are liable for that patient. And it's hard to give anesthesia and do the procedure at the same time.
Absolutely.
You can't see if that patient breathing.
No.
You over there telling them, hey, give 50 more fentanyl because they're moving.
Right.
It's not because they are moving because every time they're in pain. They might just be restless and just trying to fight the fight, or they have restless leg syndrome if they're doing a leg procedure or arm procedure. So, but with a CRNA, we can do MAC anesthesia, in places. We can do general. We can do regional. We can do blocks in these offices.
Exactly.
RN can't do that.
No, they can't. And you can't operate on someone and direct the anesthesia at the same time because it's two different jobs.
Yes.
And as the surgeon is focused on doing his surgery, whatever it is that he's doing, and they like what we call cadavers, which means that they want the patient to just lay there like a dead body and not move. They don't want them to twitch. They don't want them to cough. They don't want them to do any of those things.
Which is fine.
Which is absolutely fine in certain cases. However, you need a professional there that is going to be able to get a patient. In order for a patient to lay that still, you need to give them certain medications. You need to be watching certain components of the way they're breathing, how they're breathing, because you got to think about this. If you're not moving, you're not moving. And when everything stops moving, then, you're going down a slippery slope to death.
Right.
But, you have a CRNA, they're able to intubate the patient, and guess what? You can still have that patient laying there very still, not moving, allowing the surgeon to be efficient and focusing on what he's doing. And, then they're doing their job, you're doing your job, and it works together to get the best outcome for the patient. So CRNA, Certified Registered Nurse Anesthetist. Are we nurses? Yes. Are we registered nurses? Yes. But did we go to school to get an advanced degree? Yes. I have a story. Of course I have a story. I always have a story for everything.
Yeah, let me hear a story.
So when I was doing my clinicals as a nurse, we were in a office, and it was a GI clinic. We were doing a colonoscopy. So I look over, and one of the nurses is I see a person giving medicine. And I'm like, okay. And so, we keep sitting there, and I look over, and patient still. And I was like, oh, okay. And so after the case is over, I was like, who is that? And the doctor tells me, oh, that's Ashley. And I was like, oh, okay. And I was like, so she puts the patient to sleep? I was like, what does she do? And he said, oh, yeah. So she went to school and got a little certification. And so she puts the patients to sleep for me. And so I'm thinking in my mind, oh, well, shoot, I'm going to do that, because I'm thinking this is like a 6-month certification. You go and take a class and learn how to, put the patients to sleep. I had no idea she was a CRNA. And so it's very, very different than a little certification. Like you are actually an independent practitioner. You have moved out of the realm of taking orders, which is what RNs do, to doing what you choose to do as far as your practice, in your practice. Right.
And let's not get it twisted. They're great RNs, but no RN can go into the facility and give on their own no medications without a doctor's order. Now, a CRNA, Certified Nurse Anesthetist, can.
Yes.
We go into places, we basically write our orders and give our orders to our patient. It's directly given. We don't have to take orders from a surgeon,
No.
that say, hey, you need to give this. You basically look at them and say, okay, if you want to make them happy, you can get some saline, like we usually do. But we know basically what amount to give the patient to keep them safe. So we're always on safety. You always have this RN that come in the room. Oh, its blood pressure is 80, and you're looking like at your iPhone.
Okay.
Because we do this for a living. We used to this, and they pay us well to do this job.
Yeah. If the blood pressure go too low, we got something for that. If it's too high, we got something for that.
Yes.
I mean,
We
if
have
it
a lot of
happens,
drugs.
we usually have something for it.
Yes, and we can reverse
Pretty much
almost
anything.
everything except ketamine. I can't stop the bunnies and the rabbits from coming out of the wall, but
We can help it.
yeah, we can help it. We can get some Versed.
Yeah.
And
always
Valium
help
in
it.
some cases, but
Right.
yeah, it's a situation where I don't know where the situation even arose, where the conversation is really not a conversation. It's not an RNA versus CRNA. It's usually CRNA versus anesthesiologist, because we embarking on a profession that they want full control of.
And it also, kind of boils down to the politics and the money of the whole thing.
Yeah.
Because, and let me not belittle or sound like I'm downplaying anything. They are doctors. They
We
do
love
go to
anesthesiologists.
Yes, we absolutely do. They go to
respect
school
them.
for 4 years. They get a medical degree, and they go into the the practice of anesthesia. But we also go to school for our 4 years, and we become registered nurses, and we work, and then we also go to school for anesthesia. We do it differently, and as independent practitioners, we are able to do everything that they are.
Mm-hmm.
And so for them, that becomes a sore spot, because they feel as though they should be better than us. I'm just going to say it. I'm just going to put it out there. I said it.
Well, I'm gonna say this.
David might say it more eloquently, but I said it.
I have a lot of respect, for
Absolutely.
anesthesiologists. Actually, I want my daughters to be anesthesiologists.
I would want my daughter to be as well.
So, I know great anesthesiologists, like Tony Smith, Sonia Johnson, Erica Watch. There's some great anesthesiologists
Absolutely.
out here that they are very good at their craft, and I could never say nothing wrong about them.
Right.
And they will get on you and have no problem getting in your face when you're doing something wrong, or if they may just have a question for you to see how knowledgeable you are about what you're doing. And there's nothing wrong with that, because they have the authority to do that. But you do have some CRNAs that are very smart, very good at what they're doing, and they're very competent at providing anesthesia. And they know this.
Mm-hmm.
But you do have some trashy CRNAs, and you have some trashy anesthesiologists.
It goes both ways.
So just because you pass tests, doesn't mean you know how to put somebody to sleep. So
I think that's in any
it's a lot of
profession.
common sense. Yeah, it's any profession. You have some good surgeons, bad surgeons, good anesthesiologists, bad anesthesiologists, good CRNAs and bad CRNAs. But vascular anesthesia, we try to screen the best we can. We screen and we get experienced people, and
That's right.
you don't want nobody going in there just overdosing people and don't know what to do and saying, oh my gosh, what do I do? We strong at making sure that we the hiring process is very strenuous.
Right, because, we want good people, and no matter what procedure you're having, whoever your anesthesia provider is, whether it's an anesthesiologist or it's a nurse anesthetist, you always want the best person, that's putting you to sleep, that's putting your mother to sleep, that's putting Granny and Pawpaw to sleep.
Mm-hmm.
You want the best person available. So, more often than not, anesthesia providers are, very safe or very good, and,
Yeah, and it comes from all walks of life. As a person is competent to do their job that they went to school for, and make sure nobody is injured or basically is going to be dying in your hands. I've had people, they don't care what color you are, but some people do. I've had black people walk up to me and say, "You don't know what you're doing. Why are you putting me to sleep?"
Isn't that sad?
Yeah, it's sad. It's somebody who looked just like you and say, "I don't want you to put me to sleep. And they'll come out and say, "I want a white man to put me to sleep." So I say, "Okay, I can take me a break." I'd be like, "I go get my white friend."
That's right.
I'd be like, "Hey, they just want you to put her to sleep," and she'd be like, and they be mad, like, "Why?" I said, "Because they want a white man. You go in and do your job."
That's right.
So, and I've had white people that say, "I don't want you to touch me because you don't know what you're doing," and it's a profession. I really, I don't care what you look like. I didn't put KKK members to sleep. They took off their shirt and go in the OR and they look at you and say, "Brother, that was in a past life. Make sure you bring me back." I really don't care. I don't care if you KKK or you Huey P. Newton. You still going to sleep and my license depends on it. So I don't care.
Every single patient.
Yeah. So
we used to have prisoners come in all the time.
Oh yeah.
And
Aryan Brotherhood.
Absolutely.
Crips and Blood.
Absolutely.
Shots.
Shots.
I done had one man say, you a thug. You don't need to be putting nobody to sleep. Look how you just explaining this consent to me." I said, "It take one to know one." You sitting up here, I bet you know about this consent now, in layman's terms, and not all these big words, I can sit here and I can be very, I can pick some very big words to present to you.
Right.
I can sound like Carlson Banks and have the presentations up.
But can you do the dance?
Carlton?
Yes.
Yeah, I can do the Carlton. Yeah, I can do it. I'm not finna do it, but I can do it. My hip it ain't like it used to move.
Not your hip.
We are vascular. We provide anesthesia services for office-based anesthesia, ASCs, and even small hospitals. Thank you for the opportunity that you allowed us to come in to your families to service you while you were sleeping with excellence. Thank you. We are vascular.
We are vascular.
I fell asleep last night, watching drops on my pillow.
All right, we're back. So, last topic.
Okay.
Big question though, that a lot of people come into the OR and they're afraid, and especially African Americans, my brothers, we don't like to go to the hospital. We ain't going to the hospital for nothing. You gotta be dying to go in there. Grandma and pull you in. You go in there and they like, do you have high blood pressure? He gonna tell you no. Do you ever had a stroke? No. He can't even lift his arm. You ever had a heart attack? No. Okay. You take Viagra? No. Just
definitely no.
Just lie
about everything.
Just lie about everything.
Just for no reason.
No reason. Just lying. And but this is a big question. If you do not want to have surgery, and you on the table, basically you're in pre-op, do you have to have surgery?
No, you don't. Not on any day of the week.
Mm-hmm.
Not at any hour. No, you don't. That is your choice. That is one of your choices and one of your rights as a patient. There are, you have elective cases, and you have emergent cases, and you have urgent cases. And especially on elective cases, those are the cases that you schedule with the doctor and you tell them, I'm going to come in at 5 o'clock in the morning and you're going to, do my procedure at 6 a.m. and you're going to, take out my gallbladder. That's an elective case. I'm going to... Yes, or you're going to go in and you're going to have an augmentation, a breast augmentation, or, an abdominoplasty or something. Those are all very, elective surgeries. If you get there and you decide you don't want to do it, All you have to say is, no, I don't want to do this. And please disconnect me. I'm going to give you back your gown, and you can go home. Yeah. Nobody is going to stop you.
Yeah, that's elective cases. Even men, men have plastic surgery also. Yes, they have liposuction. They have the...
they get Botox. Facelifts. Pectoral implants.
Yes, pec implants. They get the boobies removed.
Biceps and triceps.
Yes, they have a lot of surgeries. And, and they require anesthesia. And, that's an elective case.
It is.
Now, what about an emergency case?
Okay,
if they come in emergent, all right, off the street, knocked out, they come in, and the family members say, hey, he's not going back. What happens?
He's going back.
He's going back. Because he's unresponsive.
He's unresponsive.
And we found him on the street. But majority of the time, the family member's not there.
No.
They just rolling in.
Right. And if you're unconscious and you're not able to speak for yourself and you're not in your right mind, you're going back to have surgery, because then it becomes a life-saving event.
Yes.
But if you are competent and you don't want to have surgery, even if it's an emergency, you don't have to have surgery, and we can't touch you, because if we do, then it becomes assault and battery.
Yes.
And I'm not going to jail.
Your face you ain't made for jail?
I'm not made for jail.
Man, I sleep on my stomach, so I know I ain't going to jail. I am not going to jail.
I'm not going to jail.
No.
I don't get paid enough to go to jail.
What about a situation where we have, let's say the patient get pushed all the way back to the operating table. We finna put them to sleep.
Okay.
And they say, I don't want to do this today. I don't want surgery. I do not want it. Even though he signed all the consents, what happens?
If you don't want surgery, you do not have to have surgery.
You hear that, folks?
You do not have to have surgery.
Nobody can pressure you to have surgery.
Nobody can make you do anything. This is one of the times where you have complete control. If you don't want it, you can say stop. And everybody in the room is going to stop what they're doing. If we're hooking you up to, the monitors, we're going to stop. To a certain extent during our induction. Once the induction starts, we're done.
Once you had that profile, you ain't doing too much speaking.
You're done. But if we're sliding you over onto the table or asking you to move yourself over to the table, and you decide this is not the day, this is not what you want to do, you don't have to have surgery. We will slide you right back over onto that bed and wheel you right back out. Case is canceled.
What's the word say? No means no?
No means no.
So it's not going to happen. If you say no, I mean, even if it's a cancer case, guy with stage 4 cancer, stage 3 cancer, if he decides to say, hey, what happens if he decides to say, hey, I don't want surgery today. I don't want chemotherapy. I don't want anything. I don't want to remove this mass. What happens?
That's his choice. He doesn't have to do it. Nobody can make you do any of those things. There is a case that is done. It's called a shake and bake. And it is, it's basically just a case that they are doing for patients who have like cancer in their abdomen. And the cancer, the way it grows, it just kind of grows wild, so it's not like it's just one tumor that they can take out. It's, kind of widespread. And so instead of them like going in and kind of trying to take it all out, they go in and they just kind of put hot chemo, and they shake and they shake and they shake for like an hour and a half. And they take the cancer out. They, take the chemo out, they close the patients back up, and then, another 6 months, 7, 8 months, they have to do it again because it's grown back. And, you can keep getting the shake and bake as long as you want to, but if you decide you don't want it, you don't have to have it.
Okay. Well, that was a very informative show.
Yes, it was.
Yeah. So I want you to join us next week. This is season 1 of Insommnia. And where we are informing the community about anesthesia and addressing the fears and concerns of patients and their questions about anesthesia. Thank you. I'm David with Vascular Anesthesia.
I'm Crystal with Vascular Anesthesia.
Y'all be blessed.
I fell asleep last night, watching drops on my pillow. Drops on my pillow. I have no peace of mind in this